So this is a graphic whereas the entire FC region is derived from humans. Then the humanized, we just have a few areas of sequence that are derived from an animal. And then, again, of course, we have the fully human antibodies. So in figure 16.8, they give you guys kind of a list or summary of some of the most common monoclonal antibody therapies. And again, you don't need to know the names or these specific molecules, what they're targeting, but just keep these in mind. We're going to be talking about a few specific examples and how they are used, how they affect the immune system. And again, since we just talked about the naming conventions, you can practice with those by whenever we're talking about a monoclonal antibody, thinking to yourself, okay, so we have that name. What type of antibody is that? Okay, so the first use for monoclonal antibodies can be to prevent allograft rejection or a transplant. And this is very important because of the prevalence of something called graft versus host disease, which we'll talk about more in the organ transplant lecture. And here, the particularly bone marrow that is infused into a patient actually recognizes that patient as foreign and begins to attack them. So you can reduce the chances of this happening by removing mature T cells from a graft. So you can do this using an anti-CD52 therapy, and this depletes mature cells in a bone marrow graft. And then, like I said, these T cells might recognize the host as foreign, so depleting them reduces the chances of that. We can also use an anti-CD3 antibody, which causes more broadly T cell immunosuppression. And this monoclonal antibody will inhibit TCR signaling. And this, however, can still stimulate pro-inflammatory cytokines due to its intact FC region. So here, this is a fully mouse antibody, as you can tell by the name, and therefore, it's more likely that the patient will mount an immune response against it. So a couple of other monoclonal antibodies that are used in transplant are anti-CD25, which helps reduce IL-2 and therefore reduces T cell activation. This is particularly used for kidney transplant rejection to prevent the rejection from happening. Then so this is actually, the next example is not a pure monoclonal antibody. Instead, it's still a biologic, but it's a fusion protein. So this is actually a soluble CTLA4 protein that's fused to an immunoglobulin. And this actually can bind to the co-stimulatory B7 molecules on APCs, and this will prevent those antigen-presenting cells from interacting with the CD28 on the surface of T cells. So this is approved as well for rheumatoid arthritis. It helps dampen the T cell response. So we can also use monoclonal antibodies to help deplete autoreactive lymphocytes. So in the autoimmunity lecture, we talked about some of the different mechanisms of how autoimmunity can happen. So you can use monoclonal antibody therapy to target those mechanisms and therefore improve the symptoms of an autoimmune disease. So one of the most common antibodies used in this is rituximab, or anti-CD20 in humans. And this depletes all B cells except for plasma cells. So in this case, you still have the cells that are producing antibody, so you will retain your immunity to things that infections you've seen before or been vaccinated against. However, this helps treat diseases with an autoantibody component, as it helps prevent all the less mature B cells. So, as we talked about with transplant rejection, you can also use anti-CD52, and in autoimmunity, this is used to help dampen a T cell response, particularly in MS. So, this will target for destruction mature T cells. And unfortunately, in MS, it can cause a brief but still severe flare of symptoms. So before symptoms improve, sometimes they briefly increase. And that's because this antibody can actually stimulate the release of pro-inflammatory cytokines initially. So scientists have also tested anti-CD4, and this would be to target CD4 positive helper T cells. And these seem to work well in animal studies. However, when translated to human studies, they actually, first of all, fail to deplete the primed CD4 T cells, so the cells that we're interested in depleting. And they also have the side effect of depleting all T cells in the blood. There was a clinical trial that followed patients, and 6 years after they were given this treatment, they still had reduced T cells in the blood. So anti-CD4 is typically not used in humans. So we also have antibodies that can block inflammatory cytokines. And again, these are very useful in treating autoimmune diseases. So we talked at the beginning about biomodulators. So this is also, these antibodies are called immunomodulatory therapy. So they're helping to modulate different parts of the immune system, not necessarily getting rid of certain cell types. So one common treatment is anti-TNF alpha, and this is used for rheumatoid arthritis and Crohn's in particular. And this antibody will bind TNF alpha, and there's also a biologic protein also used in psoriatic arthritis that is a recombinant TNF alpha receptor fused to an Fc protein. There's some antibodies that don't work well in humans. So IL-1 blockade is very effective in animal models of autoimmunity, but is not effective in humans. Instead, we can see IL-6 receptor therapy is as effective as anti-TNF alpha therapy in blocking symptoms of rheumatoid arthritis. And also, interferon beta blockade is effective in MS. And this helps actually reduce IL-1 produced by the inflammasome. So again, I really want you guys to think back to previous lectures, in particular the autoimmunity lecture, where we talked about the different mechanisms that cause autoimmunity. And when you look at those different diseases, it might be helpful to go back and listen to that lecture again with this in mind. You want to be thinking, okay, so what is the mechanism causing disease? And then what might I be able to target in order to help improve that disease? So this is some clinical trial data in patients with rheumatoid arthritis. And here you can see several different measures. We have the pain score, number of swollen joints, and amount of C-reactive protein. We can see the comparison of patients who received a monoclonal antibody treatment and those that received a placebo. And as you can see, it's pretty dramatic how much better the patients do who have received a monoclonal antibody. So finally, biologics can also block cell migration. So we touched on this a little bit when we talked about corticosteroids, but immune cells need to interact with proteins in order to enter the tissue of interest. In infection, that's good because those cells helping to clear the infection, but in autoimmunity, those cells can cause further inflammation and tissue damage. So some examples here are an anti-alpha-4 integrin antibody that blocks the binding to VCAM1 and MAdCAM1. And this stops immigration of lymphocytes, monocytes, macrophages, etc. into tissues. However, as you might expect, this can cause increased susceptibility to infection. So in this figure, we just have a diagram of how this might work. So typically, you'd have these cells in yellow rolling along the endothelium, and when they come in contact with these integrin molecules, they will bind and therefore transit across into the tissues. However, if you give someone a monoclonal antibody, this antibody will bind to those integrins, thereby blocking the ability of the cells to stick to the molecules on the endothelium and therefore preventing them from entering tissues. And you can see here, this is in MS. We have patients that received this alpha-4 integrin, and this is comparing the number of new lesions in the brain. And there's a really dramatic reduction in new lesions when this extravasation is blocked. So there are also, besides antibodies, we have a few other commonly used small molecules or hormones that actually have immunomodulatory properties. One of these is statins. So these are often prescribed for high cholesterol, but it has the additional effect of decreasing the expression of MHC2 on the cell membrane. And it's thought that this may be due to decreased cholesterol in the cell membrane. We also see that vitamin D3 actually decreases IL-2 production by dendritic cells, but unfortunately this is only at doses high enough to actually cause hypercalcemia and bone resorption. So these are just two examples of other drugs, and it's important to keep in mind that drugs that might not necessarily be associated with the immune system can still have immunomodulatory effects. So we also need to talk about how the administration of an antigen or a therapy can be used to manipulate the immune response. So we'll talk about this in the allergy lecture, but one common treatment now for allergy is to give small amounts of the antigen, for example, peanuts, and slowly increase the amount of antigen that's given to the patient. And over time, this helps the patient's immune system change more towards an IgG and IgA response, which is less harmful than IgE. There's also, if you orally administer an antigen, this can induce oral tolerance, like we discussed in the mucosal immunity lecture, and this helps induce a Treg response. And finally, you can also give drugs that help shift the response generally towards a Th2 response, which is often less damaging. So in summary, today we've talked about biomodulatory medications and how they can be used to treat too strong immune responses. And we talked about specifically transplant as well as autoimmunity. We also discussed several different classes of drugs that have varying specificity and toxicity. So some good examples of this are corticosteroids, which are very broadly effective, yet can have many off-target effects, compared to monoclonal antibodies, which have very specific targets and therefore fewer side effects. So it's really important to think about when you might want to give each type of drug. You have to balance these pros and cons of the different drugs. And finally, we really focused on monoclonal antibodies, which is an emerging therapy, as these offer the ability to target and reduce specific parts of an immune response. So I hope you guys learned a lot about biomodulatory drugs. In the next few lectures, we'll be discussing parts of the immune system that relate back to this, such as organ transplant and allergy. Thank you.